flying tomorrow, 2:49, I will bring your test package with me. So if you come up to Klein, it's on the second floor. It's a really big room. It's actually really nice. And if you want to see your exams, I'll have them with me. Okay? So you're gonna that at 4 o'clock. I'll be there from 4 to 5 tomorrow. Okay? I know that's not on your syllabus, but I'm letting you guys know when I'm also at office hours. That's 2:01 office hours, but now I'm letting you guys kind of hijack those because I didn't have them today. I didn't have office hours today. So I will bring these with me as well if you fail to come pick these up. So let's finish out the lecture. And let's talk about acute brain trauma. So the insult to the brain, obviously this could happen with a strike to the brain if the brain was exposed, like during surgery, or if there was a tremendous accident and the cranium was open. But it's more common that it's blunt force versus open, for obvious reasons. So an insult to the brain, when the brain strikes the front, this would be considered a coup injury. So a head injury, a coup injury occurs on the site of impact, let's say the front, with the object. And then the contra coup is the brain smacks the front, and then it recoils and it hits the back side in the skull cap. So the contra coup injury occurs on the opposite side that the brain was impacted. Coup versus contra coup. Much more common with blunt force versus open, but can happen in either way. Now we have diffuse versus focal brain injury. So diffuse, we call it diffuse axonal injury, or DAI. It may occur in the absence of blunt force. Usually involves acceleration or rotation, where you can see from these pictures, here's the normal architecture of a healthy axon and a healthy nerve. And this rotational, or this twisting motion, causes trauma to the axon by a twisting and a tearing. And that eventually leads to permanent death of that particular cell. And unfortunately, where we see this take place is the shaken baby syndrome would fall into this category. So the child may not have been struck, may not have been hit, but there was enough motion that caused those gentle or delicate axons to actually shear. So that would be diffuse, where you have this injury all throughout the brain. And then focal or local injuries would be grossly observable in certain locations. And that's what we're going to cover next. These are going to be contusions, concussions, hematomas, and hemorrhages. And we can see these very obviously if we look at the brain tissue themselves. So a concussion. We're going to start out with the least, and we're going to work our way to most aggressive. Concussion is really the least aggressive of the four. There's a reversible altered consciousness that takes place. Somebody is confused, they wake up, they don't remember their name, they were knocked out, they come to. Very common with football players or hockey players or any impact sport. Happens obviously in boxing as well. Mixed martial arts becoming a lot more popular these days. So there's no contusion, meaning there's no laceration or damage to the parenchymal tissue of the brain. So the brain tissue itself is functional. Amnesia could be permanent or temporary. They can't remember a series of events. And we really don't understand what pathogenesis is. So the brain is obviously impacted, it's struck, and the nerves are stunned, but they do recover. So you can see causes of concussion in children. Most commonly is a fall that takes place. Some of these other ones are struck by object, collision. I like collision. That's probably like with a wall or another child, to be quite honest. Okay, but this is the most common way that children actually receive concussion. So a contusion, let's look at this picture. A concussion would not have this. You would not have these obvious damages to the brain. You can see lesion here and a lesion here. So these are actually lesions or damage to the parenchymal tissue of the brain, where you have either a laceration, bruising, or even necrosis that happens because the impact was so strong.
Is that what killed this individual? Was this contusion?
Yes, this individual died because of multiple contusions to the brain over on this side right here. So this is obviously post-mortem, right? Okay. Just to clarify. So we have concussion. We move up to a level of contusion. Okay? Can you see a contusion with an x-ray? No. You see contusions usually by other imaging modalities like CAT scan or MRI. Okay? And as we work our way up, what you're trying to rule out are things like hematomas. And then hemorrhage is the last category that we're going to get to. So, and hematoma is a local accumulation of blood. This is a brain bruise. So the vessels rupture, the blood's leaking out, it gets into the space of the brain tissue, and it clots. And we have three main types. We have an epidural, a subdural, and then the subarachnoid, which we usually see with a contusion because it's deep into the brain tissue itself. Right? Subarachnoid is not a superficial wound. You with me? And so with our epidural, if we look over on this slide here, this is looking down mid-sagittal. So an epidural hematoma is usually arterial blood because of where it's located. The dura peels off the skull. Here's where the fracture is right here. And you have pooling in the epidural space of blood. So this is usually arterial blood. In contrast, a subdural is usually venous blood. As you can see that the dura is still attached to the skull, and the pocket of space that's created is subdural. And so this is a venous circulation that perfuses it. And we can see that with imaging. If you see a hemorrhage, or excuse me, a hematoma under imaging, you can identify, right? The radiologist can be able to identify where is it located anatomically, and do we think it's either epidural or subdural. Now, if we look at subarachnoid, we're really talking about a pretty aggressive lesion that's usually seen with contusion. And this picture on the lower left, is an epidural hematoma at autopsy. Epidural hematoma. So that would be arterial in makeup. Now, if we look over here, we get active bleeding. Here's our subarachnoid hemorrhage. Right? So our subarachnoid hemorrhage is you have active bleeding into the subarachnoid space. It never really clots off because it's an active bleed. So it's classified in a hematoma category, but the subarachnoid hemorrhage is an active bleed, which is our fourth category. So this guy is kind of this in-betweener. It's between this category and the next one, which is our cerebral hemorrhage. This would be the most severe, although, I mean, at the level of hematoma or hemorrhage, they're both rather severe. Any one of these can kill you except for concussion. Multiple concussions, the worst thing would be probably altered brain activity. I mean, the person may have long-term amnesia and not remember certain things. But a contusion can kill you. You saw autopsy of the one patient that was dead after contusions to the brain. So here you can see an active hemorrhage. This is obviously a hematoma now because it's clotted off. This is post-mortem. Vessel ruptures, and it's actively bleeding. So this would be a brain bleed. Okay, so if you have an injury, let's just take, for example, this is a football injury. Okay, the kid gets hit really hard, doesn't get up. Okay, the coach goes out, athletic trainer goes out. Definitely have a concussion because they give them salts, they bring them back, they take them off on a stretcher. Now they're going to look at their head for a while. And what they're really worried about is there an active bleed. Is there a bleed that's not stopping, right? And the vessel itself could rupture by any one of these. And this is the trauma that we're talking about with a lot of athletic injuries. But all of these happen in patients that aren't, older patients, of course. But these are things like hypertension, high blood pressure. If you have high blood pressure in the vessels perfusing the brain, it could cause a rupture if it's too high. if you have an AV malformation, this is an arteriovenous fistula that forms. It's an abnormality, a developmental abnormality. And because of that abnormality, there is a weakening of the vessel wall in that location. And when it's pressurized, it starts to kind of balloon over time, like the aneurysm question that was asked earlier. And saccular aneurysms, here's kind of the network of this circle of Willis, and you can see that this anterior communicating artery, this is 40% of these aneurysms that are in the brain are in that location. And you can see from the middle cerebral artery, 20%, 34%, and then a very low percentage at this bifurcation, probably because this is coming from the basilar artery, which is a rather big artery, and this must developmentally be more robust. Okay, so you can get these saccular aneurysms that form in any one of these locations. They could go on for years kind of undetected, you didn't even know it, and it becomes an issue when the patient becomes hypertensive later in life. And so here is a picture of a saccular type aneurysm. We call them saccular because they legitimately look like a sac. Okay? The other type of aneurysm, you don't see it in the brain as often, is called a fusiform, where it's kind of equally big on both sides. And it's kind of like bulges out on both sides. Saccular bulges on one side. Is one more dangerous than the other? If it breaks, it's dangerous. So you don't really know until it ruptures. After it ruptures, then you usually get a hematoma. Here you can see this was a saccular aneurysm on the patient's left side. It ruptured, and then obviously you have a hematoma that results. Okay, so other pictures of saccular aneurysms. Here's the one we just looked at. Here's one. This is the vessel right here coming in. Here's the vessel coming out. And so this is an aneurysm that actually hasn't ruptured quite yet, but you can just imagine it's like a balloon that's overinflated. Over here, this is histology, and this is the lumen of the vessel, and here's the lumen of the vessel that's coming out, and this is the bulge that's coming out. This dark red right here, this is blood that was still left over inside of the bulging balloon saccular aneurysm. Okay, so neurovascularly, we can actually treat now some of these using endovascular stents. So they come in with a balloon into the head, and they get into smaller and smaller lumens, or diameters, with a balloon. And over the balloon is loaded a stent graft. Now, it's not just a stent, it actually is a tube that has a stent on the outside of it. Right, so the blood can flow down the lumen and not leak out of the metal stent. So as we get better and better of making them smaller and smaller, we being the field, we can treat smaller diameter vessels in the head. Questions? Okay, so concussion, contusion, laceration, damage, hemorrhage, hematoma, and then active hemorrhage. Now, a lot of times you're going to see one crossing over the other. Could you have a contusion and actually have a bleed, an active bleed? Absolutely. If the bleed goes away, then it results in a hemorrhage, and you hope that it's not large enough and that it kind of is resorbed. The body kind of breaks down that clot and it just sort of goes away over time. Head trauma is kind of a really big deal. All right, so if we look at the last segment, we've covered a lot of diseases today, guys, right? A ton of diseases. And we're going to finish up with the miscellaneous bit, other, okay? But we're going to tee up a couple of really interesting ones. So let's go back to meningitis. This one's kind of disgusting, so I really want to dim the lights to give you the full effect and see if anybody will hurl. Meningitis. Meningitis is active on this campus periodically. Yep. Okay. It's very common in areas that are tight housing communities, like dorms or army barracks, military barracks. This is an infection of the leptomeninges. That is a word that refers to the combined space of the dura and the arachnoid matter. It can either be bacterial, fungal, or viral. Could be all three, any one of them. The symptoms are usually a headache, problems with light, or photophobia, where bright lights give you a headache or they bother you. Stiffness of the neck, rigidity of the neck, and general irritability, just of the patient, kind of flu-like irritability. How do we diagnose? Well, you usually will do a lumbar puncture and look for leukocytosis, right? Death of white blood cells in the area. Or you'll look for evidence of the bacteria, the virus, or the fungus that's causing it. So etiological agent is either bacterial, fungal, or bacterial, fungal, or viral. Acute pyogenic meningitis. This is actually what's shown over here on the far right. So this one is an infection, a bacterial infection. It's a pyogenic bacteria, and so there's a thick superlative exudate that's covering the brainstem and the cerebellum. That's this cottage cheese looking exudate that's coming out as a result of leukocytosis, or death of white blood cells. Right, so the bacteria is winning. Two different main types are listed here: Streptococcus pneumonia. So Streptococcus pneumonia is what typically affects the very old and the very young. So pediatric and geriatric is streptococcal. What college-age students come across typically on campuses in dorm rooms is the Neisseria meningitis. If it's caught early, it's actually really easy to treat. If it persists, it can actually be fatal, but most people get treated pretty quickly because it's rather uncomfortable. Now, moving away from meningitis, if we look at Creutzfeldt-Jakob, Creutzfeldt-Jakob, CJD. Creutzfeldt-Jakob is an interesting disease. So this one affects and is a mutation in a normally occurring protein part, or what we call a prion. So the normal proteins that we see are shown over here on the far right with these sort of like pinkish colored boxes. And then if they can go through a mutation, and they do at times, they go through a mutation and they form into what we call this sporadic case, and that actually forms aggregates of the protein. And that protein, as it aggregates, you can see how it aggregates with a normal prion, and it converts it into a spontaneous or sporadic case where it aggregates out. And what it does is it resides in neuronal tissue, and it causes a spongiform appearance. And that's over here. You see all of these vacuole white open spaces? And that open space is causing damage to that neural tissue because these proteins are aggregating into the tissue and causing this spongiform morphology to persist. So what happens in these cases is rapid dementia because the brain's not functioning correctly. Lots of widespread cellular death. These cytoplasmic vacuoles, or are these white open holes that looks literally like sponge. So the nervous tissue now has the spongiform appearance. And it's dying. The tissue's dying because these prions are changing the architecture. So these prions that spontaneously mutate is very, very rare. Spontaneous mutation usually happens about 1 case per million. But Creutzfeldt-Jakob has become very, very popularized in the media because there's a cow form of it called bovine spongiform encephalopathy, mad cow disease. Okay, and so in the bovine or the cow population, you have these mutated prions that do show up, on occasion, very rare, but they do show up, and it causes this spongy form to take place, and the cows act crazy. That's what's called mad cow disease. So, what's the connection to us? Well, so the spontaneous mutation in humans is very, very low. It doesn't really happen very often. What ends up happening is if you have infected cattle and you consume beef or cow parts that are contaminated with infected nervous tissue, then the prions transmit from bovine to Homo sapien. And that's the most common form of transmission, is eating infected meat. So it doesn't mean you have to eat the brain tissue. It just means that you have to eat meat that was contaminated with brain tissue. And if you've ever been to a slaughterhouse, it's not that far-fetched to think how that takes place, unfortunately. Without grossing you out too much, there are regulations that are in place, but when we slaughter animals in a slaughterhouse, it's not exactly clean. Okay? And so trying to segregate the herds is really important, and having processes in place, because these prions are really, really small protein parts. They exist as really, really tiny particles. And so it doesn't take much to infect the meat. Over here on the left image, so the right image is showing that spongy form. On the left image is the protein immunostain in the tissue. So you can see a vacuole right here, a vacuole right here, a vacuole here, there's one right here. But all of this would eventually rearrange this tissue to look like this. So all of the brown stain are mutated prions in that nervous tissue. And those mutated prions are going to turn this region of nervous tissue into this if it went long enough. Creutzfeldt Jakob. Okay, this is a sort of a review from last week. We're going to talk about here multiple sclerosis. And as we look at multiple sclerosis, this is what type of hypersensitivity? Type what?
4.
Type 4. Why?
Cell-mediated.
It's cell-mediated. It involves primarily CD8 positive T cells. And these CD8 positive T cells search out and attack the myelin within the patient. So it's a demyelination disease. It's an autoimmune disorder. And the oligodendrocytes that are there in the central nervous system that are responsible for making the myelin, they actually respond by creating scar or plaques. So after the myelin has been attacked, the oligodendrocytes are ramped up to create more of a scarring over the neuron versus remyelinating the neuron. In this lower left image, you can see a plaque lesion right here outlined in red. This is the ventral horn right here, or a lateral ventricle, excuse me. And this red plaque lesion is all demyelinated white matter that should be staining white, as you can see surrounding it. And it actually is lesioned off from an MS patient. You can see up here kind of the mechanism that is being explained. So here we see the blood-brain barrier, and we actually see the infiltration across the blood-brain barrier of immune cells, CD4 positive T cells. And they actually respond with an inflammatory response, but also by targeting and killing off the myelin. At the level of the vessel, you can see the activity of the vessel is facilitating this by recruiting microglia, activated microglial cells, to come in and facilitate this CD8 positive T cell autoimmune disorder. Now, there's been lots of studies within multiple sclerosis looking at etiological agents. And it's somewhat inconclusive. They've wondered, are there environmental triggers? Are there things that predispose people to multiple sclerosis at a higher level than other populations. And so here's some of the epidemiological data that we have. Now remember, epidemiological data is data where you're following patient populations. It's not necessarily cause and effect. It's retrospective typically, where you're reading data and you're looking backwards saying what happened. Okay, so epidemiological data shows disease especially common in Scotland, Scandinavia, and Northern Europe. Epidemiological data also suggests that its prevalence is higher as you're further away from the equator. So is there some connection between lack of sun and MS? Don't know. That's why there's a question mark here on environment. Genetics definitely plays a role. Multiple sclerosis tends to run in families genetically, but it's not clear that it's transmittable from one generation to the next, like a lot of other inheritable diseases. Here's an interesting fact that is a little strange, but there's some epidemiological studies that show that MS is more common in certain parts of the world, as I just mentioned. But if you move from an area with higher risk to an area of lower risk, you acquire the risk of your new home if you move prior to adolescence. Right. If you move prior to puberty, your risk factor for MS is in the new area. So it kind of suggests that there's something, maybe environmentally, prior to puberty, that either triggers it to come on or not. Again, not solid cause and effect. This is just epidemiological data that's saying, okay, what's going on? We're trying to look at trends within MS. Okay, we look at Alzheimer's. And Dr. Miller is going to talk quite a bit about Alzheimer's. It's one of the most common types of dementia. And he's going to talk about a number of different dementia types of diseases. But it is the most common form of dementia. It's not the only, it's the most common. It tends to strike our elderly population, so it's called a disease of the age. The disease itself is lesions that show up. These are amyloid plaque lesions that occur in the extracellular environment. In addition to these lesions, you get these tangles of fibrillar protein that shows up in the neural tissue. So it first shows up and presents itself in patients as a disorder of higher brain function. So what ends up happening is people start forgetting, bless you, certain typical things, like what's your address, or what was the name of your pet, or what is the name of your pet, what's the name of your granddaughter, what's the name of your son. So these are first occurrences or impaired higher order brain functioning, or it might be simple mathematics, or it might be, what is this object right here? Oh, that's one of those structures that you use for, it's right there. It's yeah, you use that to hold stuff, and it's a water bottle. Yeah, it was right. I was about to tell you that's what it was, a water bottle. So that might be how that conversation goes, where they start forgetting certain things. Okay. Now, histologically, what's going on? As you can see in this panel, A, B, and C, here's our amyloid precursor protein. Here is it stuck inside of the cell membrane, and you've got cleavage sites located in these three different regions. And here's the enzymes that cleave: beta, alpha, and gamma secretase. And so when we cleave here, we get a soluble fragment that can go out. And this soluble fragment can dissociate from the AB peptide. And the problem with the AB peptide and this soluble fragment, if they dissociate from the membrane, is these form these aggregates, and these form these amyloid fibrils. And so the aggregates in the fibrils form these plaques and these neurofibular tangles. So on the far left, this is a picture of the neurofibular tangles that show up as these lesions. This is a picture of our beta amyloid plaques that show up in the tissue. Extracellular lesion. So you have intracellular lesions and extracellular lesions. And then over here is a stain of them together. So you've got our intracellular problem and our extracellular problem. They're forming these plaque scar lesions in the brain tissue because you're cleaving off these amyloid proteins in various spots, and you don't necessarily want them to be showing up in the brain tissue this way. So here's one of the dilemmas is, which happens first? Do you get Alzheimer's and then you show up with brain lesions? Or do the brain lesions cause the Alzheimer's? And we don't know the answer to that. So at autopsy, when we see neural tissue, we look and we can find patients that have amyloid plaque lesions and they didn't have Alzheimer's. So is the question that maybe they didn't have enough lesions to reach that threshold? We don't know the answer to that yet. All right, so the last one that we're going to look at today is Parkinson's disease. And here's a normal pattern of the substantia nigra. And here's a depigmented segment. You can see that it doesn't have the same pigmentation as our normal substantia nigra. So what's so important about the substantia nigra? Well, this is a portion of the brain, midbrain, and it is responsible for manufacturing dopamine. Dopamine stimulates the substantia nigra, which limits unwanted movement. So if it's not working correctly, then you have a tremor that takes place that typically is mitigated by dopamine on the substantia nigra to cause unwanted movements to cease. Most of the cases are idiopathic, meaning we don't understand what caused it. We have a better understanding of the other ones that we talked about, like Parkinson's, Alzheimer's, and multiple sclerosis. But with Parkinson's disease, we just don't really understand what's causing it. We see it in certain patients that have high brain trauma, right? We see it in patients that aren't involved in activities that cause a lot of brain injury. Questions from today? Okay, so next week we're going to be on our hosting behavior, right? Dr. Miller? Please come with questions, you guys.